Hello, my name is Ken Kinter, and I'm an assistant professor at Rutgers University. The purpose of today's presentation is suicide, facts, approaches, and interventions. As always, my contact information is on the title slide, and decided to go with the festive shirt today because this isn't the happiest subject in the world. Before we get started with that, I have to give some acknowledgements. This is coming to you because of something called the State Hospital Psychiatric Rehabilitation Initiative, which I've been a part of for many years. It's a project between Rutgers University and the New Jersey Department of Health to improve conditions at New Jersey state psychiatric hospitals, both for patients and staff. Because of the generosity of the grants from the Department of Health, that helps make our mission possible. So we are grateful to them for that. So let's get started with today's topic of suicide. So we're going to start out by talking about some of the more recent statistics about suicide, particularly demographic, different populations that are at risk, some of the new trends, how suicide has moved up in the rankings of different types of mortality in the United States. And then we're going to shift over into talking about suicide on an individual level. How you talk, the different types of suicidal ideations and risk, being able to talk to someone who's suicidal, and some additional resources. Again, this is a very serious topic. I wouldn't recommend you just catching this video and then embarking on a career in suicide prevention, but there are some great trainings and some great materials out there that can help you. And if you work in the field of mental health, it can help you make your experience in the field better. And you may have some personal experience with this as well. So starting off with the statistics, not that long ago, suicide moved into the top 10 causes of death in the United States, and it looks like it's moving on its way up. It's going up every year. Part of the reason for that are the effectiveness of the means. Firearms and hanging are becoming the two most common means of suicide. Overdose was also very common, however, it's much less reliable. You can see some of the populations here. White people are more than twice at risk as non-white. The highest range of completion is 55 to 64 years old. People that are divorced, widowed, and single are much more of a risk than people that are married. And there is a pretty major impact. Each suicide leaves survivors behind and also has a financial cost to it as well. Here's the breakdown by age. Suicide is the third leading cause of death for people aged 10 to 14, and it moves into second for 15 to 24 and 25 to 34. Number one is accidents. And then as you see it goes up through the age bracket, it starts to reduce in its ranking. However, that's also because people at 35 to 54 and 55 to 64 are starting to die of other things in greater frequency. People age 55 to 64 actually have the most completions, not the most attempts, but the most completions. But that makes it the 8th leading cause of death for that population. There's been a steady increase from 1999. The suicide rate's been increasing by 1%, and then it's recently increased to 2% per year. So you can see the frequency of attempts and how many completions there are per attempt. Other populations that we were talking about that are at risk are people that are diagnosed with different forms of mental illness, depression, addiction, schizophrenia, conduct disorder, autism. Teenagers are at much higher risk to attempt, not necessarily to complete, but they definitely attempt a lot. And the LGBTIQ plus community is at a much higher risk for attempts, nearly in the 3 to 4 times other people in their demographics. So here we broke out, these are the causes of death, the top 10 causes of death in 2014. The ones that you can't see right off the top here. In blue, we have cancer. In red, we have heart attacks. And then in this green, we have chronic pulmonary diseases. So these are your top 10, and there's suicide as it just nudged in there. And that's 2014. When it first broke into the top 10, I believe it bumped out car accidents, if I have that correct. And this slide, which I'm blocking a little bit, you can see how some of these numbers have gone up. The types have remained pretty steady. Accidents and lower respiratory diseases switched. And again, intentional self-harm, suicide, you can see how those numbers have gone up. In fact, it's moving closer. It's going to be moving into 9 and 8 before very long if the trends continue. So the other interesting part of this is as the suicide rate continues to climb, it starts to climb to rates that we haven't seen since the Great Depression. And we go from 15 to over 17 deaths per 100,000. It was 22. And actually, as we sit here now in 2020, there are at least 3 states that are over that 22 mark. I believe it's Montana and Alaska are both over that as well. So some of the increases, men in the 50s, women in their 60s. At this time, a lot of issues with baby boomers, worried about their financial security, experiencing medical problems. They do have access to high quality medications, very effective medications at suicide. We also have a huge problem with suicide in our military, both active and retired. I believe at this point in time, the Marine Corps has actually seen its highest rate of suicide, but there's some additional and better data about that. So we have this very grim forecast of all of these numbers going up. One statistic we didn't talk about was females aged 10 to 14. Historically, one of the lowest ranking groups in terms of suicide is actually one of the fastest climbing, I think over 200% during the time of the study. So getting to the individual level here, not all suicidal ideation is the same. There's different levels to it. So the information on this slide attempts to break that down. It's not uncommon for people to think about suicide. More people do think about it than don't, but it's a matter of degree. So we're going to start with maybe from the lowest degree into higher degrees. So at the low end of the spectrum, we have death wishes. And that might just be, I want to be out of this pain. I want to be gone. I want to be away from here. Or maybe someone has passed and they want to be with that person. So it's a wish for death, but it's passive. Maybe accompanied by hopelessness. One of the main things that causes people to be suicidal is the idea that things aren't going to get better. It's not just that they're bad, it's that they're not going to get better. So then we move into suicidal thoughts, and these can be fleeting thoughts, just the quickest glimmer through of whether suicide is an option or a good option for this. Then it moves into ideations, and the difference between thoughts and ideations is ideations start to get more specific. Not quite as specific as a plan, but maybe a method, or maybe the circumstances. So it's the pieces that eventually assemble a plan. So by the time we get into a plan, which is, okay, if I were going to do it, how and when and the specifics, this is where things start to get concerning. If someone is getting to this point where these thoughts are sort of crystallizing and becoming clear. There's also suicidal intent. Does the plan that they put in action, the intent is to die. It's not to send out a message or anything along those lines. Death is the goal. So that's the intent. And again, we're deeper into the little scary territory here as far as how safe someone is. Another concern is access. Do they have access to medication? Do they have access to this method? People kind of choose a method and stay with it. So if something happens to that method, it takes them a while to come up with a new method. They're not necessarily interchangeable. So access and that method are both important. Is there a family history? Do they have people that have attempted? Do they have people in their family who've completed? Has someone famous or someone they looked up to attempted or completed suicide? I know when I worked in the emergency room, when Kurt Cobain killed himself, we got many, many, many kids coming in who he was their hero, and they took that very hard, and we did a lot of work after that. And I know in the state hospital where I work now, when Robin Williams completed suicide, people were very touched by that. People who'd never met the man but were very familiar with his work were very affected by it. Other aspects of suicidality or impulsivity is if you're talking about someone who attempts suicide spontaneously, say after a breakup, and then they have another breakup, they're at risk again. This is as opposed to someone who might be more of a planner, who may spend a couple weeks hoarding up medication for the attempt, not knowing when they're going to do it, but preparing for it. So those are two other aspects. Is this an impulsive person overall, or when it pertains to suicide, or is this person slow and methodical? One of the scary parts about talking to people about suicide is they usually don't tell you exactly how bad it is. So there's the intent that they tell you, the intent that you get, and the vibe that you get, but then there's this other piece that they keep from you. And they may not want to let you know how close they are or how close they've come. And that's the scary part. And that's one of the reasons why you don't want to underestimate it. You probably don't know the worst of it. So the case approach, I don't want to go into too much detail in this, but just to indicate that someone who's suicidal, it's a confluence of things. They may have a history with it. And then there might be something more recent, like relationship troubles or financial troubles or something that brings it to the surface. And then there may be something very small right in the immediate future that sets it off. So I just want to get a look at it. A person can be okay, but then that little thing can put them back into it again. So we assess for suicide over time, what's going on immediately, what's going on in the recent past, and what's going on in the distant past. Some other points to make up. Self-mutilation is not necessarily suicidal. Self-mutilation is an attempt to deal with emotional pain by causing physical pain. It's not the same thing. Very often someone who self-mutilates, usually it's the form of cutting, can also be burning and other things. They report not feeling it, and they keep doing it until they feel it. And that's kind of how that works. A few of these points I can't stress strongly enough. You can't make someone suicidal. Talk to them about it. You do a much greater disservice by ignoring it and letting that person suffer and not have a place to bring it than by bringing up an unpleasant subject. Don't keep the secret. Depending on your job, you may be legally obligated to respond. And on another level, you probably feel morally obligated to respond. You don't want to be the last person that talked to someone and then find out they're gone and then look at yourself in the mirror and say, could I have done something? You don't want to be in that position. The saying I always have is, you're always on the better side of reporting. You would rather report and have that person be mad at you and have them be gone. If someone is suicidal, refer is needed. Have someone that you talk to. Have someone licensed. Have someone that's a professional. Don't go out on this limb by yourself. And the last point on this is to use direct language. You don't want somebody saying, well, are you sort of kind of maybe not really thinking about doing something to hurt yourself? You lose them in the words. Direct. Are you thinking about killing yourself? Not harming yourself, because that's that self-mutilation point we were talking about. Are you thinking about killing yourself? What's the closest you ever came to killing yourself? Is there a situation where you could see that you would attempt suicide? Something along those lines, something that's direct. Come right at the person. You're doing them a favor. Another important point to bring is the best crisis intervention, suicide prevention, is prevention, is to come in ahead of time. Early in the relationship, get the suicide bug out there right on the surface. Have you been suicidal before? Have you attempted before? What were the circumstances? You want to know, because if it came to that circumstance before, it might come to that circumstance again, and you want to be ahead of it when that happens. So bring it up at intake. You want to bring it up before the crisis rather than bring it up during the crisis. The same way that you talk about goals with the person. I kind of like the balance of, so this is what you want to have happen in your life. These are the goals you're shooting for. And then these are the bad things that have happened in your life. And this is how you've responded then. That way you've kind of got the highs and the lows covered. So to summarize the very cheerful content we've been going over today, suicide recently entered the top 10 causes of death in the US. It has been steadily increasing, and I see no reason that that's going to change. In fact, I'm guessing it's actually going to accelerate. Certain populations are at higher risk. I mean, you don't want to make an assessment completely based on someone's demographics, but you do want to be listening if someone is at a couple, high-risk groups. There are different levels of suicidality, from passive to, imminent risk. And you do want to be able to at least assess that and get a report from the person of where they are. Do they feel safe? Critical to talk about suicide and start it at the gate when it's easy. You can ask about suicide like you ask about anything else in the past at the beginning, and then that's something that you can build upon. People may not be completely honest with you about how suicidal they really are, and that's why it's critical that you tell someone about it and that you consult someone about it. It's always better to talk to the person about it than to avoid it and think that they're okay. And don't keep it to yourself. Don't keep the secret. Critical point. There are a lot of great resources for additional training. This is just meant to be an introduction. If you look at the American Association of Suicidology, the Columbia Suicide Severity Rating Scale is the best scale that I've seen at assessing suicide. There's mental health first aid. There's a version of that for youths and for adults. And I threw a couple hotline and resources in here. And here's some of the information where where this presentation came from. So that's all for this particular presentation. If you have any questions about this, don't hesitate to reach out to me or check out some of the resources that are on there. And I hope to see you again very soon, and you take care.